Okay, well, welcome everyone. It's great to see such a big turnout. My name is Peter Sainsbury. I'm a public health physician. I'm not an expert on medically unexplained symptoms. In fact, I have to say, I don't think I even realised there was such a thing as a medical model until about 10 years after I graduated, when somebody told me there was something other than a medical model. It wasn't the sort of thing they taught at my medical school, that sort of thinking. So it's delightful to be involved in this session today, where I think we're going to explore issues around medical models, perhaps not using these terms all the time, and biopsychosocial models, and maybe even ecological models that take us out into systems theory and the relationship between individuals and societies and the environment at large, and thinking beyond what we often call the medical model. So welcome to everyone, and welcome particularly, of course, to our speakers. Unfortunately, Lorimer Mosley can't be with us today. There's some illness in the family, but Lorimer sent us a video, so we'll be watching that at the appropriate time. Hopefully, if the speakers keep to time, we'll have a bit of time for questions at the end, and Skye and I will be doing our best to make sure they do. And so we'll get started straight away, and the first speaker is the conference organizer, Dr. David Beaumont. I'm going to keep the introductions very brief and do it as I introduce each person. David is an occupational physician and sees many patients with chronic pain and chronic fatigue and other medically unexplained symptoms, often associated with multiple chemical sensitivity. David's particularly interested in the biopsychosocial model of health and illness. So I'd like to invite David to the stage now, please.
It's 1988. I'm 27. I've gone straight through medical school, general practice training. I'm a GP. I call in the next patient, Eileen, 57, with her husband. She walks in slowly, and he helps her into her seat. Now remember, in general practice, you don't know what is coming in next. You don't know whether it's a child with earache, or a woman for a smear test, or a terminal patient coming to have their morphine dosage amended. He said she's come for her medical certificate for the sickness benefit. I looked into the notes, and sure enough, there was the last entry, 6 months, medical certificate, rheumatic heart disease. I've got 7.5 minutes. I'm seeing 8 patients an hour. I hastily look back in the notes and see that she's not worked for 20 years. And there it is, a cardiology assessment, rheumatic fever as a child, rheumatic heart disease with mild impairment of cardiac function. Whatever was causing her disability was not that. I looked at my watch, I hastily considered what to do, and I did what every doctor before me had done. I wrote rheumatic heart disease, 6 months. Now, I'm just going to get the clicker. Fast forward 30 years, it's 2018. I'm an occupational physician. I've been asked by the insurance company to see a client of theirs on an income protection policy. She's not worked for 10 years with a diagnosis of ME, chronic fatigue syndrome, and fibromyalgia. Geraldine, was 57 too. She came with her husband too. She described to me how she has unrelenting and profound fatigue. She has unrefreshing sleep, but lots of it, 12 to 16 hours a day. Some days she manages to get up and watch television in the lounge with her husband. He's given up work to be her primary carer. I asked what treatment, what management they'd had from her GP, and they both looked at me somewhat puzzled and said, "He said there was no treatment." I was filled with a profound sense of sadness. Just because there was no treatment didn't mean there was no management, no hope, no life. So, I clearly struggled in that situation. I'd let Eileen down in the same way that the system had let Geraldine down. So medically unexplained symptoms, what are they? Well, they're actually a hodgepodge of symptoms, of conditions affecting every system, every part of the body. Actually, that means you all see them, every single one of you. This is but scratching the surface of the many terms for these conditions. They're medically unexplained symptoms because we can't explain them by the medical model. They're conditions, they're actually collections of symptoms for which we have no clear understanding as to the underlying pathology. There's a lot of research, which I'm sure Ros will refer to, which tells us that there are some immune abnormalities which can be identified. We don't know whether that's cause or effect, but there's clearly something. They're multi-symptom conditions, so they're collections of lots of different symptoms, huge crossover in the symptoms between the different conditions, and they often coexist. ME, chronic fatigue syndrome, with fibromyalgia, with irritable bowel syndrome, with chronic headache. So, do we struggle with them? Is it just me? Is it the rest of the system? Well, Ikushla-Langdale says that we struggle with them. In fact, she told us how GPs struggle with them when she presented at Congress 2 years ago. She did one of the parallel streams, and she presented her PhD research looking at referrals to a gastroenterology clinic. And she was particularly interested in the GP behaviors around those referrals. And what she found was that although there are really clear guidelines for the management of functional gastrointestinal disorders like irritable bowel syndrome, that the GPs didn't follow them at all, not one bit. And the referrals were mostly completely inappropriate. The local clinical guidelines says, don't refer unless. And she asked them, so why are you referring? And they gave her lots of reasons, but the commonest reason was persistent symptoms and repeat attendances. And just quietly between themselves, they said to her, well, if they're on a waiting list for a gastroenterology appointment, they're not coming to see me. Imagine how the patients felt. She asked them, they said, do you know what? We're really unhappy about this. We're really dissatisfied with the service we're getting. He wasn't listening to me. All he did was refer, but I clearly need some tests. So I was talking about this to Mark Lane, our new college president, who's a gastroenterologist in Auckland. Mark said, oh yeah, I know. Do you know, I spend half my time in clinic explaining to people that they don't need an endoscopy. In fact, he said, you know, I had this really sad case the other week, a young woman come for a gastroscopy, and I just sat her down and I said, do you think the fact that you were abused as a child may have something to do with your symptoms? I was telling the story about Mark Lane to Jonathan Christiansen, the outgoing New Zealand president of the RACP. Jonathan's a cardiologist in Auckland, and he said, tell me about it, tell me about it. Half of my patients in cardiology clinic have got non-cardiac chest pain. We do the investigations because we have to. I mean, imagine not doing a stress test on a middle-aged guy referred with chest pain, but we know it's going to be normal. He said, yeah, do you know, I was chatting to one the other day. I just got a bit of time at the end of clinic, and I was chatting to this guy, and he was telling me how he's just been made redundant from his job of 30 years. He said he was devastated. There had been no recognition of the huge contribution that he'd made to his company over that time. And Jonathan said, do you know, that's what was making him ill. So, as I look back to why I had struggled so long, I looked at my medical training and I thought, well, how were medical unexplained symptoms dealt with in my training? And the answer is almost entirely they weren't. I remember seeing actually a neurological case, a guy with a really bizarre gait, the neurologist in front of the patient used a term that he could, because it was very medical. He said, yes, Mr. Smith's problem is supratentorial. Your laughter tells me you know what that means. It means it's all in his head. He actually said, yeah, next step is brain biopsy, just to exclude Jakob Creutzfeldt disease. But they knew that was going to be negative. They knew what the problem was, but they didn't know how to tell the patient, and they didn't know how to manage it. My son's a 6-year medical student. I spoke to Matt last week, and I said, Matt, what medically unexplained symptoms, how are they dealt with in your training? And he said, we had a lecture in which they were mentioned under different models of medical practice, but yeah, no great answers there. So we're not trained how to do this. The motto of my medical school was Ars Longa Vita Brevis. I didn't know what it meant. I knew how it translated because I'd done Latin, because I thought you had to do Latin to be a doctor. The art is long, life is short. I didn't know what it meant because I was a scientist. I was being trained to be a scientist. Medicine is a science. And for the first 2 years, I didn't see a patient. So I was taught biochemistry, physiology, anatomy. And then I didn't start at my clinical years, and I was taught the medical model. And here's the medical model. Patient presents with symptoms. Doctor takes a history, examines, investigates, reaches a diagnosis, and treats. When that works, it's pretty special. It's very slick, it's very neat. If it doesn't work, we revise the diagnosis. We take a history, we examine, we investigate, we revise the diagnosis, and we treat. If that works, it's great. If it doesn't work, we go around the loop, maybe one more time, and then we monitor. Or if you're a GP, you can always refer. Here's the problem. Up to 30%, in some studies up to 50% of presentations to GPs are for medically unexplained symptoms. What do we do then? Because we don't know what to do. We are not taught what to do. So actually, one of the things we do is to give it a name. Let's call it myalgic encephalomyelitis, or let's call it fibromyalgia. What does fibromyalgia mean? It means aches and pains in the muscles and fibrous tissue. It's a medical term that describes the symptoms, but it's a diagnostic label. Myalgic encephalomyelitis, it has been agreed internationally that there is no evidence to justify a title that suggests that it's an inflammation of the central nervous system. So here's the other problem. 27% of attendances at secondary care clinics are for medically unexplained symptoms. In a Kushler-Lindale study, that was nearly 50%. That means nearly 50% of your clinics are for medically unexplained symptoms. This is all our problem. And because they're medically unexplained, because we don't know what they are, there is no clear solution. But there are answers. So the World Health Organization said, do you know what? The medical model is not good enough. It actually regards disability as being a feature of the person that needs treating. If there is no identified diagnosis that you can treat, then the best thing to do is nothing, according to the medical model. That's what had happened to Geraldine. That's what had happened to Eileen. The more useful model might be called the biopsychosocial model. Can I just have a show of hands? I do this every time I talk about this condition. Can I have a show of hands? How many of you have heard of the biopsychosocial model? That's high. That is high. In non-doctor healthcare audiences, it's generally around 20% of the audience have heard of it. In doctor audiences, particularly GPs, it's around 50% of the audience have not heard of the biopsychosocial model. I wasn't taught the biopsychosocial model in my training 30 years ago and a bit. So here it is. What it says is that the influences on our health and indeed on disability are in part physical, biological, related to our genetics and our makeup, but far more so our psychological milieu and the social environment in which we exist. It was Dr. George Engel who first described the biopsychosocial model, and he said, he was a physician and psychiatrist, and he said, half of the patients in my clinic are not explained, their condition is not explained by the medical model. We need another model that ties in the psychological and social elements. And he said, I'm going around to conferences, RACP Congress 1977, and I'm hearing doctors saying, well, medicine's neat entirely. It's all explained by the biological sciences, unless it's not. And actually, we should just embrace the medical model, except we need more than that. And we should concentrate on real diseases, focus on organic disease rather than the psychosocial elements of human malfunctioning. How judgmental is that? So he said, look, here's the model. Take it or leave it. If it's a good idea, it'll work. If it's not, it won't. The problem was it was never operationalized, never included in medical student training. This is how you do the biopsychosocial model. So has it worked? Well, this was World Health Day last year. This is a human rights issue. This is endogenous depression. I was taught that endogenous depression is a condition whereby people have low levels of serotonin for some unknown pathological reason. So it's a medically unexplained symptom. You treat the low serotonin with medication. If it works, that's okay. If it doesn't, then you try something else. But actually, we're doing patients harm. Medical students and doctors have been misinformed. I'm actually going to start to bring this to a head. I'm going to say that in the notes for these lectures are how we actually do talk to patients currently and how we could. I'm going to, within the pack, there's also the relationship between these medically unexplained symptoms and childhood trauma, and actually adult trauma as well, but particularly childhood trauma. 2.7 times more likely to have a medically unexplained symptom if you've had childhood trauma. This guy, Dr. David Brady, this is a blog that he's written explaining to sufferers with these conditions why that might be linked to their symptoms and their condition, even if we don't know what they are. And this is what they said. They said, thank you for writing about it in this way. When I heard fibromyalgia was linked to childhood trauma in the past, it's always sounded like another version of it's all in your head because the physical basis was not explained. It was said as though fibromyalgia was a psychological symptom rather than a physiological process. So health is not the condition of being well or free from disease. So Harry Burns told us that it's actually the ability to adapt and self-manage in the face of social, physical, and emotional challenges. For me, I just say in the face of life's challenges. David Beaumont yesterday gave us a new definition of health. Health is living life more purposefully, leading lives are worth living. That's what we need for our patients, these sufferers of these conditions. The Mari model of health adds spirituality, which is the purpose and the meaning. So, in short, the medical model is reductionist, we need more. Medicine is an art, and the art of medicine is to apply the science in the context of a person's whole life. What we need is a model of practice. George Engel wrote the biopsychosocial model as a model of practice. It never became that. We need a model of practice which enables people to have health in all domains of their life: physical, psychological, family, and spiritual. Thank you.